So today we shall learn about the modes of mechanical ventilation. So the types of mechanical ventilation. So here we have got this negative pressure ventilation. Negative pressure ventilation, it was used in the olden days and nowadays it is not used. So here in this negative pressure ventilation, the patient is placed in a chamber and negative pressure is applied to the chamber. As you can see here, in case of chest cuirass, so only this negative pressure is applied to the thorax, and in case of iron lung, the head and neck of the patient is outside the chamber and the rest of the body of the patient is inside the chamber, and the negative pressure is applied. So when this negative pressure is applied, then air will enter the lungs. So this is negative pressure ventilation. It has got many disadvantages, so it is not used and it is an obsolete. So now what we are using is the positive pressure ventilation. So in case of positive pressure ventilation, we have got these phases of breath and the phase variables. So here, so in the beginning what happens is, that is the changeover from expiration to inspiration. So here the changeover from expiration to inspiration. So this is called as the trigger variable. Then we have got the inspiration. So this is the inspiration and the inspiratory hold. So this is the second phase of breath. Then we have got the changeover from inspiration to expiration. This changeover from inspiration to expiration is called as cycling. So what cycles or what changes from inspiration to expiration? So that is called as cycling variable. And then we have got expiration. That is, this is the expiration and the expiratory hold. So now coming to the trigger variable. So this trigger variable, it is what triggers or what changes from the expiration to inspiration. That is called as trigger variable. It is the variable that determines the start of inspiration. So here in case of controlled mandatory ventilation, it may be a time triggered breath. For example, if the patient respiratory rate is 12 and I ratio is 1:2, then your inspiration will be triggered once in every 5 seconds. So next we have got pressure triggering ventilation. In case of spontaneous breath, whenever patient has spontaneous attempts, then there will be a pressure triggering of breath. Whenever the airway pressure it goes below zero, that is -1 to -2 centimeters of water, then triggering of breath occurs. This is called as pressure triggering of ventilation. So here, as you can see here, so the airway pressure or the pressure within the tubings is zero. So whenever patient triggers a breath, that is it becomes -3 centimeters or -2 centimeters of water, then it triggers the breath. Now the inspiratory valve opens and there is flow of air to the patient. So now another triggering is the flow triggering. This flow triggering, it is also seen during spontaneous breathing. So in case of flow triggering, what happens, this is the more sensitive, it is more sensitive to the patient's inspiratory effort and therefore it requires less respiratory or inspiratory work, and this is the preferred one when compared to the pressure triggering, because the work of breathing is less and therefore the weaning duration also will be decreased. Early weaning occurs. So in this diagram we can see, this is to explain the flow triggering mechanism. So there will be a low flow of gas at the end of expiration. Also there will be a low flow of gas in few ventilators. In most of the modern ventilators the flow triggering is seen. So there will be a low flow of gas from the inspiratory limb to the expiratory limb circuit. Okay. So whenever the patient takes or makes an inspiratory effort, then some amount of this gas goes to the patient, and the result what happens is the amount of gas which is going to this flow sensor, that is expiratory flow sensor, it is decreased. So this decrease in the flow to this expiratory flow sensor, it is detected by the ventilator and it is sensed as an inspiratory effort, and hence the inspiratory valve opens and there is a flow of gas to the patient. That is, there is a next inspiratory effort. Support is given to the patient. So usually it is kept around 2 liters per minute. So that means whenever this change of flow from the inspiratory to the expiratory flow is change is it is less, it is around 2 liters per minute, then inspiration is triggered. Next we have got this limit variable. This limit variable, it limits the pressure, volume and time and flow during the inspiration. So here what happens is, for example, we have got a pressure limited breath. That means pressure is not allowed to rise a certain limit, or we have got a time limited breath, we have got a flow limited breath. So that means the flow will not increase above the preset value, or the flow or the duration of inspiration, it will not exceed the particular time. So this is called as this so that means it is not allowed to rise above a preset value. For example, the flow will not rise above a preset value of say 40 liters per minute, or the pressure will not rise above a preset value of say about 20 centimeters of water. So breath delivery continues here, but the variable is fixed at that preset value. So next we have got this cycle variable. Cycling means what? That is changeover from inspiration to expiration. So here we have got pressure cycle breaths. Pressure cycle breaths, here it occurs whenever there is a high airway pressure. For example, whenever in between patient coughs or there is kinking of the circuit. So in these cases we have got this pressure cycling of breath. Volume cycle breath, you have seen, you see in case of volume control ventilation. More precisely speaking, in case of volume control ventilation, it is not the volume cycling, it is the time cycling. Okay. So time cycling, for example, when you keep respiratory rate of 12 and IU ratio of 1:2, then your inspiratory time will be around 1.68 or 1.7 seconds approximately. Then what happens after 1.7 seconds, then cycling occurs, that is changeover from inspiration to expiration occurs. In case of pressure support ventilation, here flow cycling occurs. That means whenever the inspiratory effort of the patient decreases, that is when the flow of gas decreases to a preset value, say around 25 to 30%, then the termination of inspiration occurs. So time cycling, in case of continuous mandatory ventilation, you get to see this time cycling will be seen. So next we have got this baseline variable. It is the variable which is controlled during expiratory phase and it is called as a baseline variable. So here pressure is controlled during this expiratory phase. So before going into the modes of mechanical ventilation, we should know the basics of this the scalars, that is the flow time scalar, pressure time scalar and volume time scalar. So this is the flow time scalar here, where this time is along the x-axis and flow is along the y-axis. So here these are the different types of the flow time graphs which we can see. So here the square type of flow time waveform, that means it is a constant flow waveform. So constant flow waveform, this is which is used in volume control ventilation. Next, this is ascending flow or accelerating ramp. This is not used because it is not physiological, and when you use this one, the patient will struggle or patient will fight on ventilator, because the basic physiology is in the beginning of inspiration, the flow of gas requirement is more. So that is why here this will not be physiological. Then you have got this decelerating flow or descending ramp. Here at the beginning of the inspiration, your flow of gas is higher, and as the inspiration progresses, the flow of gas slowly decreases before it reaches zero. So here this is more physiological, because at the beginning of the inspiration only we have got the demand for the flow of gas is more during the beginning of the inspiration. This one you have to remember, and this is used in pressure control ventilation. Next we have got this sine flow. This sine flow, it is seen during spontaneous ventilation. Next we have got this exponential decay. So this is the pressure time scalar, where this pressure is along the y-axis and time is along the x-axis. So here you can see in case of volume control ventilation, so the constant flow waveform. So because of this constant flow, there is a constant or continuous rise in pressure, that is an exponential rise in pressure occurs, and then it decreases. In case of pressure control ventilation, as I have told, in case of pressure control ventilation, it is a decelerating flow or the descending ramp. So here what happens here is initially there is a increase in pressure, and then because of the flow of the gas keeps on decreasing, the pressure is kept constant. Okay, this is the pressure control ventilation. And this is the volume time scalar, where the volume is along the y-axis and time is along the x-axis. So here the first half of the this scalar, it indicates the inspiratory tidal volume, and the next half indicates the expiratory tidal volume. So now coming to the modes of mechanical ventilation. The mode of the mechanical ventilation, it depends upon the breath type and also the pattern of that breath delivery. So what type of breath type it is? So it is a type of breath, whether it is a mandatory breath, it is a spontaneous breath, or it is an assisted breath. And also the pattern of breath delivery, how the breath is delivered, whether it is a continuous, it is a timing of breath delivery, and also like timing of breath delivery, that is a continuous mandatory ventilation or intermittent mandatory ventilation or continuous spontaneous ventilation. And also depends upon the target control variable, whether you are keeping it volume as a target or the pressure as a target, that is volume control ventilation and the pressure control ventilation. So now coming to the type of breath. In case of type of breath, we have got this mandatory breaths. So mandatory breaths, in case of mandatory breaths, the timing of the breath, the beginning of the inspiration, that is the trigger variable, and this inspiration, cycling, expiration, everything is controlled by the ventilator in case of mandatory breaths. In case of spontaneous breaths, here in case of spontaneous breaths, the triggering, it is by the patient. That is the timing. The cycling is also by the patient because it depends upon the flow cycling, and also the tidal volume is also decided by the patient. In case of assisted breath, only part or whole of the breath it is given by the ventilator. For example, in case of assisted spontaneous breathing, only the beginning of it will be by the patient. Okay, that is the triggering will be by the patient, and rest in case of assisted spontaneous breathing, that is the triggering will be by the patient and also cycling will be by the patient, and some amount of support will be given by the ventilator. That is, here only part of the support is given by the ventilator. So next, coming to this target control variable. Here this control variable, it is the independent variable. Here we are going to fix this tidal volume. For example, in case of volume control ventilation, we are keeping this volume as constant. So, and the pressure, it changes it depending upon the compliance of the lungs. When the lung compliance is better, then the pressure will be less. And when the lung compliance is less, or it is not, when the lung compliance is bad, then the pressure is more. So next, coming to this pressure control ventilation. In this pressure control ventilation, pressure is kept constant and the volume is variable, or volume changes based upon the compliance of the lung. Better the compliance of the lungs, volume increases. Less the compliance of the lungs, volume decreases. So now coming to this timing of breath delivery. In timing of breath delivery, we have got this continuous mandatory ventilation, intermittent mandatory ventilation, and continuous spontaneous ventilation. So now coming to this continuous mandatory ventilation. In case of continuous mandatory ventilation, this controlled mode. In this continuous mandatory ventilation controlled mode, so in case of continuous mandatory ventilation controlled mode, here in the indications are whenever the patient cannot breathe, or in case of drug overdosage, patient is paralyzed, there is phrenic nerve injury is there in patient with tetanus. So in the case of control mode, here what happens here is the sedation and paralysis is necessary. Patient cannot breathe spontaneously in case of continuous mandatory ventilation controlled mode. So everything, that is the triggering, inspiration, cycling, expiration, everything is decided by the ventilator. Tidal volume is decided by the ventilator, and patient cannot breathe in between. So this is continuous mandatory ventilation controlled mode. So here you can see this is the graph, that is pressure time graph in case of continuous mandatory ventilation control mode. So patient is not able to breathe in between. So here, what are the characteristics of the breath? Type of breath. So it is a mandatory breath. And triggering mechanism. Triggering mechanism, it is time triggered mode in case of this continuous mandatory ventilation. Cycling. How this cycling occurs? It is usually a time cycled breath. So, what are the complications of continuous mandatory ventilation? Here, because in case of continuous mandatory ventilation, sedation and paralysis is required. So, rapid disuse atrophy of diaphragm can occur, and also there is a potential for apnea in case of mechanical or electrical failure occurs. So, next is continuous mandatory ventilation, assist ventilation or assist control mode. Here almost most of the ventilators, what we see, this is CMV or ACMV. It is this continuous mandatory ventilation control mode. It is replaced by this replaced by ACMV in most of the ventilators. So here the triggering, it is both by the patient and also time triggered mandatory breaths will be there. So here in case of assist control mode, what happens we shall see. So here this is the mandatory breath and this is the patient triggered and mandatory breath. This is also patient triggered mandatory breath. So here only triggering is allowed by the patient. So rest of all the factors, that is the inspiratory time, the expiratory time, what is the baseline pressure and inspiratory hold and tidal volume, everything is decided by the ventilator. So part of the breath, it is controlled by the only the triggering mechanism is by the patient. It is both. So the type of breath, it is a mandatory and also assist. So both assist or control. Triggering mechanism, it may be a time triggered breaths or it may be patient triggered breaths. In case of patient triggered, either it can be a flow triggering or pressure triggering. Next, coming to the cycling mechanism. Cycling mechanism, it is a time cycle. So what are the advantages? So advantages are here the patient work of breathing is small in case of assist control ventilation. So patient can, it allows the patient to control the frequency and hence the minute ventilation. So patient can have control over the what breath rate he needs depending upon the condition. So and also enhance the minute ventilation. So the disadvantages are here the auto triggering is a possibility, and so we have to adjust the triggering appropriately, and also the alveolar hyperventilation and respiratory alkalosis is common. For example, when a patient with ARDS, so because it is a hypoxemic respiratory failure, so it will always stimulate the respiratory center. So what happens is patient will be having a high respiratory rate, 30, 35, 40 respiratory rate. So when we keep this assist control mode, then patient will have this almost around 40, this everything will be a patient triggered mandatory breaths will be there. So this alveolar hyperventilation respiratory alkalosis occurs. So now coming to this volume control and pressure control ventilation. So this is a volume control mode and this is a pressure control mode. So in case of volume control mode, as I have told previously, here it is a constant flow. So the flow of gas, it is constant. So whenever the flow of gas, it is a constant, you imagine a balloon or you imagine lung and you blow gas continuously. So what happens at a constant flow? So then it increases in size and also the pressure increases continuously. So the pressure, it is an exponential rise in pressure is seen. So followed by, this is the inspiratory pause and this is the expiration. So in case of pressure control ventilation, here what happens, the flow of gas, it is a decelerating type of flow. So this is the decelerating type of flow and hence the pressure is kept constant. So what are the advantages and disadvantages of volume control ventilation? In volume control ventilation, the advantages are the guaranteed tidal volume. So even with variable compliance and resistance, a fixed tidal volume is guaranteed to the patient, and also less atelectasis when compared to pressure control ventilation. The disadvantages are the risk of barotrauma. Whenever the compliance is less, then higher airway pressures are reached and this lead to barotrauma. And this is the lung compliance changes and the pressure volume loop in case of volume control ventilation. Here you can see, so this is red, or this, so this loop is the normal. So this loop is the normal one. Okay, so whenever the compliance of the lungs is better, so this loop, whenever the compliance of the lungs it improves, then at a lower airway pressure only your preset tidal volume will reach. Whenever the compliance of the lungs it decreases, so then this is the loop, pressure volume loop. So what happens here is the peak inspiratory pressure it increases. So whenever the compliance decreases, the loop it shifts towards the right. So now coming to pressure control ventilation. Here pressure control ventilation advantages are it limits excessive airway pressure and also it improves gas distribution. And it has also shown that weaning is early with pressure control ventilation. And what are the disadvantages? Disadvantages are where because the pressure is constant, the tidal volume is variable depending upon the compliance of the lungs, and also the risk of atelectasis is also present. So this is the lung compliance changes and pressure volume loop in case of pressure control ventilation. In case of pressure control ventilation, so this is the normal pressure volume loop. So whenever the compliance of the lungs increases, so this will be the loop. That means for the same given pressure, your tidal volume it increases. Whenever the compliance of the lungs decreases, so for the same given pressure, the tidal volume it decreases. So this is the lung compliance changes and pressure volume loop in case of pressure control ventilation. Now coming to intermittent mandatory ventilation. Intermittent mandatory ventilation, here what happens here is in between patient is allowed to breathe. So mandatory breaths are there and in between patient is allowed to breathe. So this is intermittent mandatory ventilation. So here what is the type of breath? It is a mandatory breath or a patient triggered spontaneous breath. So triggering in case of mandatory breath it will be a time triggered breath. In case of spontaneous it is a patient triggered. Patient triggered it can be either pressure triggering or flow triggering. And cycling, how the cycling occurs is in case of mandatory breaths it is a time cycling. In case of spontaneous breath it will be it is flow cycling. So intermittent mandatory ventilation, what are the complications? So the main problem with intermittent mandatory ventilation is breath stacking. So and barotrauma. What is breath stacking? Breath stacking means one over the other. So here what happens here is, as I've shown in the previous slide, this is the same graph. So here this is a spontaneous breath of the patient. This is the inspiration, that is negative pressure, and this is the expiration, positive. Here what is happening here is during the expiratory phase of the patient there is mandatory breath being delivered by the ventilator. So here what is happening here, the patient is trying to exhale but the ventilator is giving inspiration. So here there occurs, this is called as a breath stacking, and this leads to patient ventilator dyssynchrony and patient will be fighting on ventilator or patient will be agitated. So this is a presently an obsolete mode. This is not present in any of the ventilators. Now this is replaced by synchronized intermittent mandatory ventilation. So now coming to this synchronized intermittent mandatory ventilation. Here what was the disadvantage with intermittent mandatory ventilation? It is overcome by this synchronized intermittent mandatory ventilation. So here what happens here is the mandatory breaths are synchronized with the spontaneous breaths in order to avoid breath stacking. So here there will be something called as a synchronization window. See, for example, here in this graph if you see, so this is a patient triggered mandatory breath followed by spontaneous efforts, and here again an inspiratory effort is there by the patient and a mandatory breath. Okay, so this is spontaneous, and for example at this point, if there is a mandatory breath is to be delivered by the ventilator, then 0.5 seconds before that, 0.5 seconds before the mandatory breath, the ventilator will be sensitive to the patient's inspiratory effort. If during this 0.5 seconds before the mandatory breath, if there is a patient's spontaneous effort is there, then what will happen here is the spontaneous and the mandatory breath will become one, and a patient triggered mandatory breath will be delivered to the patient. So this time interval, it is prior to the time triggering, in which the ventilator is responsive to the patient's spontaneous inspiratory effort, is called as a synchronization window. So synchronization window, it is around 0.5 seconds. For example, I will give an example. See, we have kept a respiratory rate of 10 per minute in case of SIMV mode. So one breath will be delivered every 6 seconds. So if the patient takes a spontaneous breath, say at 5.6 seconds, so then what will happen? This patient spontaneous breath and the mandatory breath, it will become same, and patient triggered mandatory breath will be given. So this is called as synchronized intermittent mandatory ventilation. So the type of breath here, it is a mandatory breath or patient triggered spontaneous breath. So how the triggering occurs? Triggering, it is a mandatory, that is time triggered or patient triggered. And cycling, it is time cycling or pressure cycling in case of mandatory breaths. So what are the advantages of SIMV? SIMV is advantages are it avoids muscle atrophy, and it also facilitates weaning, and patient ventilator synchronized there. It decreases the mean airway pressure and reduces ventilator perfusion mismatch. So the complications are prolonged weaning. So here we have to remember why the prolonged weaning occurs when used with SIMV. So when SIMV is used alone as a mode, then it prolongs weaning. When SIMV is used along with pressure support, then it facilitates weaning. So this is important. And also complications are high work of spontaneous breathing and weaning failure when it is used as a sole mode. This is why SIMV is always used in combination with pressure support ventilation for weaning. Now coming to spontaneous modes. In spontaneous modes, we have got spontaneous breathing, continuous positive airway pressure, and pressure support ventilation. In case of pressure support ventilation, it is also called as assisted spontaneous breathing in Drager. In case of Drager ventilator, it will not be written as pressure support ventilation, it will be written as ASB, that is assisted spontaneous breathing. So this is a weaning mode. So here, what is the type of breath? So this is a spontaneous breath. Triggering mechanism, it is a patient triggered. It is a pressure triggered or flow triggered. Cycling occurs by flow cycling, as I explained previously. Flow cycling, that is whenever the flow it decreases to 25%, 25 or 30% of the peak flow, then the changeover from inspiration to expiration occurs. So in case of pressure support ventilation, we have to know what is this rise time, slope, flow acceleration percent, and inspirated rise time, all meaning one and the same. So that means it refers to the time required for the ventilator to rise to the set pressure at the beginning of inspiration. For example, we have kept a pressure support of say around 20 centimeters of water. What is the time required to increase the pressure to 20 centimeters of water? What is the time taken by the ventilator for the pressure to increase to 20 centimeters of water is called as rise time. So it is also called as flow acceleration percent or inspirated rise time. So here you can see in this graph, this is the pressure time graph in case of pressure support ventilation. Here you can see this line, it is not vertical. There is some amount of slope is there. So this is, it indicates the amount of time required for the ventilator, time taken by the ventilator to increase the pressure from say from 5 centimeters or 0 to 20 or 35 centimeters of water. This is called as rise time. So in this graph you can see this is the flow, this is the pressure. So whenever usually the flow, that is the rise time, or it is kept around 150 to 200 centimeters per second. So whenever it is more in a given patient, if that patient it is more, then what will happen is then abnormal high pressure is reached, and then the patient will go into pressure cycling. So I will repeat once again. So in case of pressure support ventilation, whenever the rise time it is too short, so then what happens here is pressure cycling occurs. That means before it reaches the given tidal volume, so or pressure cycling occurs. So normally in case of pressure support ventilation, it is the flow cycling. So whenever this flow it decreases to 25 to 30% of the peak flow, then cycling occurs. So this is the pressure flow cycling in case of pressure support ventilation. Pressure cycling occurs whenever the pressure it increases abnormally high levels, or whenever the rise time it is too short rise time, then this pressure cycling occurs. So whenever this pressure cycling occurs, then the tidal volume is less. So pressure cycling here, pressure support ventilation cycling, it is flow cycling. It is kept as 25 to 30% of the peak inspiratory flow. So in patients with COPD and asthma, flow cycle percent it is kept higher. That means at higher peak inspiratory flow only cycling occurs. That means so patient will go early into expiration. So we need more expiratory time. That is 1:3, 1:4 in case of COPD and asthma. That is why you should keep a higher flow cycle percent in case of COPD and asthma. In case of ARDS, you need to go for a higher inspiratory time. So here the flow cycle percent is kept lower, that is kept around 15% or 20%, so that the inspiratory time is more. So whenever the inspiratory time is more, what happens? Your atelectasis is decreased, so your oxygenation is maintained. So in case of pressure support ventilation, it is the flow cycling. So this pressure cycling occurs whenever patient coughs. Whenever there is a leak in circuit, this inspiratory flow it continues indefinitely. So as a safety measure, this time cycling is kept. So whenever this inspiratory time exceeds a preset value of around 1.5 to 2 seconds, so then as a safety measure, this time cycling is kept. Okay, this is all about this pressure support ventilation. So pressure support ventilation, remember, it is a patient triggered spontaneous ventilation. It is a spontaneous ventilation or assisted spontaneous breathing. So triggering is by the patient, cycling is also determined by the patient, tidal volume is also determined by the patient, and only some amount of part of the breath is assisted by the ventilator. So here only this pressure is supported, say around 10 centimeters or 15 centimeters given, so that in order to increase the tidal volume. So here in case of pressure support ventilation, here it is a weaning mode, and it can be used both with artificial airway or mask. So when we use this pressure support ventilation, so what happens? The respiratory rate is decreased. So and also the patient feels more comfortable. Okay. So this is all about the basic modes of mechanical ventilation. That is your continuous mandatory ventilation, controlled mode, and assist control mode, intermittent mandatory ventilation. Then we have got the synchronized intermittent mandatory ventilation and pressure support ventilation. In the next part, we shall know about the newer modes of mechanical ventilation. Thank you.